level, I'm trying to say we're going to leave you a little bit frustrated probably at the end of the time together that we have probably questions that are unanswered. There's also some technicality here in terms of the funding piece, which we'll talk a little bit about. But each of us has various county level and community county, public, private, if you will, strictures in place that make developing and sustaining a prevention continuum difficult. At the same time, when it's done well, we know that we can have impact on a collective basis. Apologize in advance for some of the abbreviations in the deck. I'll try to spell those out for us. But there's a lot of nomenclature here, and so sometimes the abbreviations are necessary to help us fit all the content onto slides. And I, again, apologize in advance. Let me pull up my content here and we'll see what the conversation leads to. Again, happy to be with you all. Can have you confirm that you can see? I'll see that, or somebody give me a thumbs up that you can see. I'm seeing heads nod. Thank you very much. All right. Apologies in advance too. Sometimes when a Microsoft Suite product is on my Apple device, the toggling gets a little sensitive. I don't know if any of you experienced that, but talk about an absence of integration, right? Like the Microsoft and the Apple people don't always do their work very well together. So I'll apologize in advance for that. But what we're going to try to do is have a conversation today that raises awareness that if we're interested in developing a prevention continuum, there's actually a lot of stuff available to us that we sometimes don't realize. And by bringing ourselves into collective awareness around that, if we can build then a structure for holding and sustaining that prevention work, we're far more likely to have impact. What we're going to do also is have an overview of kind of the array of prevention-related resources and supports here. Again, we won't dive deep on very many of them, but we'll spend a little bit more time on some of them because this is intended to be, as you maybe saw in the notes, kind of a pre-content, if you will, to the later session this afternoon, where we're going to dive pretty deep on system of care, its relationship to community schools, and to the California Children and Youth Behavioral Health Initiative, known as CYBHI, and its fee schedule in schools. So that's what we're going to try to do. Hopefully you'll come away with a capacity to recognize a little broader prevention continuum as it relates to your Family First Prevention Services Act and your comprehensive or your community prevention plan or your county prevention plan. We hope you'll be able to articulate a couple of reasons for which county partners could be brought into collective work on this and to maximize your impact going forward. And hopefully be able to identify at least 3 outcomes that would come from doing good kind of collective prevention work, if you will. So that's the context setting in terms of what we're going to do with our time together. Looking backward a little bit for a moment or two and into the broader environment, whole child services is a whole student, whole child services, whole person care, if you will, has been a pursuit of public systems and private systems, honestly, healthcare and healing systems for many years. And it's important to understand that that's just not possible unless the system itself is whole. You can't deliver something that you don't possess yourself. So if a system, a partnership, a collaborative in any particular county or the state for that matter, is trying to focus on wholeness, if it's not whole, it's going to struggle to do that. And what we're talking about with system of care as the anchor for prevention work is an awareness that we got to make the system whole in order to sustain and deliver effective services. Underlying all this understanding around system of care in particular is an awareness that almost every young person with complex needs was once a child with basic needs. And the system of care is often thought of as being a focus on foster youth who've been traumatized. And in reality, in many counties and communities, some of you are in these counties, they are taking a good hard look at that structure of the system of care and its functions and identifying where prevention can be enhanced, the prevention efforts can be enhanced via the system of care. Family First Prevention Services Act and its comprehensive prevention plan is very challenging to implement. Lots of reasons for this. We won't dive into this today, but the reason that that's a contextual item for us today is you don't have to wait for CPP to be perfect. There are other prevention resources in your continuum that your partners have responsibility for. And if we can maximize those, we're going to see impact in terms of entry to child welfare as well. There's this interrelatedness between all of the prevention efforts and our defaulting again into deeper end systems. Super happy in California that this idea of community supporting is gaining some steam. Not true in necessarily every county, and some counties are struggling with this idea for a host of reasons, but the state from a policy perspective is certainly leaning very assertively towards away from mandated reporting as the standard and into a mindset of community supporting, right? You heard panelists this morning in both our morning sessions talk about that. Super important to this conversation, schools are increasingly seen as kind of the centers of well-being for students, even down to the pre-K or transition kindergarten age. And so we're going to focus a little bit on schools today in terms of being part of the prevention continuum. I'm super happy to see some of you who are doing that related school-based work. And maybe most importantly, what's underlying this conversation is an awareness that child abuse prevention in many sectors at the state level, and certainly in many counties, is finally being understood as not just a welfare problem, right? For a long time, we said, well, child abuse, neglect, response, keeping children safe, that's the job of social services and child welfare. It's everybody's job. And if it's going to be everybody's job, in the public sector at least, and with our community contractors, then we have to put certain things in place, certain conditions, so that we can address that whole. I want to point out at the outset that there are kind of collective impacts to doing good interagency prevention partnership work. And this is a partial list of some of the benefits that communities around the country have garnered for pushing 40 plus years now. So the system of care architecture and function has been studied in many, many communities, in lots of states and jurisdictions. And these are the outcomes. And if you think about the reason we point this out for just a moment or two at the beginning is that often within your comprehensive prevention plan or your other related prevention planning documents, you've set a goal. You might have a logic model and you've got community stakeholder engagement that said, this is what we want to accomplish. And somewhere there could be one or two goals that are very similar to or identical to these kind of goals. And what shouldn't be lost on any of us is that the goals, reaching those goals, doesn't necessarily require more money. What it requires is collective participation, high collaboration to maximize the resources that are already available in the prevention continuum. And when we do that, we get impact, whether there's more money or not. We'll talk about that a little bit more. So this presents a dilemma in California because it's not often said out loud, but I'm not shy about being one to say it, that we don't have a resource problem in California. We sometimes talk about a scarcity of issues. And yeah, dollars are sometimes scarce when each of us sees the world only within our own department or our own agency. But what we immediately come to awareness of when we're in a high level of partnership with other agencies, other departments, in collaboration, we recognize that there are resources and supports adjacent to us. In other fields or industries, they call this other people's money, OPM, right? If you've ever done any real estate investing or financial investing, you hear people talk about investing with other people's money, OPM. That's what we're talking about. We're talking about getting to prevention or impacting our own part of the ecosystem by involving the resources and inviting the resources and setting the conditions for our partners to be present with us. Most of these prevention efforts that are listed here, and this is not a fully comprehensive list, and we will talk about some of these in some detail. It's a little bit ironic on some level that often we're serving the same youth, right? And we don't even know it. We're trying to prevent child abuse and neglect, for instance, or entry to child welfare. At the same time, schools are trying to prevent suspension, expulsion, right? And those young people are often the very same young people in county. So that irony shouldn't be lost on us. We're just pointing out, again, contextually here, that there's lots of resource out there if we can identify where the overlaps are and move ourselves forward. So embedded in this conversation is also a bit of a reality check. And I mentioned this very briefly at the outset, but once again, while the continuum is broad and the resources are more deep than we often acknowledge, it's also complicated to figure out how to weave those things together in county systems. We'll look at a couple of examples here towards the end of our time. in some counties that have done that, either conceptually or in reality. But it is easier said than done. Let's acknowledge that at the outset. Okay, so here's a list of probably what I would characterize as the major prevention-related reform opportunities. We could call this a landscape, right? If we were taking a picture of the prevention continuum in California, in every county on some level, there are these kinds of things. The community schools grants through the Department of Education. There's Behavioral Health Services Act, integrated planning now that really shifts the prevention in terms of behavioral health under what was MHSA, but there's still prevention opportunity there. Our first five work. There are local control accountability plans in every school, every county office of education, every school district. We have something called CalAIM, the Advancing and Innovating Medicaid or Medi-Cal in California. There are juvenile justice crime prevention and youth offender block grants for kids that are involved in the probation system or the youth justice system. We have school grants administered by the mental health services folks at the state level. There are other school-based prevention services in many jurisdictions. There are things like the Medi-Cal administrative dollars that we affectionately call LEA BOP. I forget what that stands for, but those dollars are available as well, right? And so with that as the landscape, that's the broad landscape, the continuum. Let's go just a little bit into some detail on some of these, because this is where we'll see the parallel alignment in terms of the objectives with your comprehensive prevention plan work that's present in some of these others. So the Behavioral Health Services Act integrated plan, what used to be known as MHSA is now known as BHSA. And within that, there are reductions in local funding targeting largely the prevention early intervention dollars. Those dollars have shifted to public health at the state level. It was just part of Prop 1 that everybody voted on about 18 months ago now, maybe 2 years, been a while. And within this also, there's a shift to housing. But I want to point out on the third and fourth bullets here, there is a new mandate. It's an enhanced mandate. It was present within MHSA, but it's now been enhanced. 35% of the new behavioral health services and supports allocation, which includes PEI, a minimum of that 35%, 51% of that has to be directed toward early intervention for young adults and children under age 25. So there's a prescription within your behavioral health services division, your Department of Mental Health, your local county behavioral health plan. They have to use 51% of those dollars in a way that helps prevent later onset or other deeper involvement in the behavioral health system, right? The local funding for that is sometimes population-based. A lot of it can be stigma reduction, community outreach. Those dollars are restricted or eliminated. Those funds are going to the state again, as I mentioned earlier. But really important to know that there's a significant source of resource in a lot of counties, especially if you're in a larger county, for BHSA integrated planning. So tune in to the BHSA planning process in your county. If you're outside of behavioral health, there's opportunity there. George, let me know if there's anything in chat that I should stop and pause and reflect on if we could.
Nothing in the chat, Kurt.
All right, thank you, sir. Additional epicenters of the prevention work in California involve the California Advancing and Innovating Medi-Cal. We'll talk about that in a little bit of detail here in a second. We've talked about school-based and community schools. If you're interested in a deeper dive on that, that's largely the content that we're going to do in the next session after the break. So we hope you'll come back and join Mike and Elizabeth and myself as we dive deep on two related prevention opportunities within the system of care. And then what we're going to also talk about just now is local control accountability plans. So this is one of the older prevention initiatives in the state that we have sometimes not availed ourselves of fully. Okay, CalAIM. It's a multi-year effort to change the healthcare delivery system within the Medicaid program. So the state has an opportunity every couple of years to petition the federal government to modify or waive aspects of the federal law. And they do that with intent. And one of those is to get upstream in some ways. And so there's now something called CalAIM, which is intended to address the combined physical and mental health needs of Medi-Cal eligible persons. It's integrated whole person care. It's stated in its objectives that it's designed to be a no wrong door, early access, whole person initiative for both adults and children. A second major goal there is to improve and integrate care for Californians. The intent of CalAIM often is to be a catalyst for justice, equity, access, if you will, to services for communities which have been underserved. And there's an intentionality also to work together to build, obviously, a healthier state, because the historic outcomes for Medicaid access in California, particularly for behavioral health, have been limited. The reason that Medi-Cal is taking this opportunity, I think, is that often when young people have complex health conditions, one system, one part of the system, one department, one agency can't serve them alone. This is the inherent difficulty in a fragmented health and human service system in California. And CalAIM is intended to, on some level, close that. So it acknowledges that multiple delivery systems are going to be required to come together. And the state's got some plans in place to do that. And more than half of the Medi-Cal spending in California is attributed to about 5% of the subscribers to Medi-Cal. And that's a recipe. It's a long-term recipe for a failed system, right? We have to figure out how to get to people when their needs are emerging. Prevention, that is prevention, right? Such that we don't allow or support their defaulting into emergency room use, inpatient room use, right? Like we want people to get care in community in their natural environment as much as possible. So these are the drivers to what CalAIM does. So it provides new revenue streams. It does extend support and services. So these are healthcare dollars that are now available to offer community supports. We won't look at them in detail today, but I hope you'll go away with some desire to dig deeper into this idea of how community supports available for Medi-Cal eligible persons in your county or community can be accessed, because there are supports for transportation, there are supports for housing, there are supports for employment, there's supporting employment supports. There's a host of supports available if one meets the eligibility standards again under Medicaid that were not available before. So the state deserves great credit for identifying how federally sourced healthcare funds can be used in very innovative ways to keep people, again, in community, right? And in the process, we're going to break down the silos and create a more coordinated system of care. Now, we're not very far into this. We're 3 or 4 years into it. It's going to take a while, but that's why CalAIM matters. Let me see if I can pull up my chat, because I did see a couple of comments in there.
Yeah, we have one.
Yeah, thanks. Go ahead, George. Want to read it?
From Brittany, we have, it seems that CalAIM requires communities/counties to slowly build infrastructure that allows us to maximize this.
Yeah, thanks, Brittany. It does. It's a slow roll, like everything in government. And there's some bureaucracy in it. It's not perfect. I could talk for probably a long time about some of the imperfections in the rollout of CalAIM. But yes, we're going to take tiny pieces one at a time, if you will. And if we can help a small cohort of vulnerable communities be more independent, have them access care more quickly, then we are having an impact. And then we go on to the next one, right? So really appreciate that. We're going to talk about ECM in just a minute, Britannia. So thank you for that. Yeah, we'll talk about that in just a second. Appreciate that. In fact, there it is. There are many aspects to CalAIM. The ones we ought to just spend a few minutes on today that kind of fit into your prevention continuum through your system of care work are two things called enhanced care management, ECM, and community supports. Enhanced care management has a lot of detail in it. Um, what it is a desire to break down the traditional walls of healthcare in ways that provide relatively intensive care management services. So think of enhanced care management almost as turbo case management, right? So there's a case manager assigned who will help the individual or the family identify and access and navigate the system that is complicated. We often lose people because of the complexity, the bureaucracy, the technicality of the system. And ECM is a vehicle whereby an individual or family can be assigned an enhanced care management case manager and have someone kind of hold the collective space with them while they figure out how to navigate the care coordination. Provides access again to this lead care manager who coordinates those services and hopefully is able to make connections with high quality, effective, efficient, timely care. Sometimes we have, in the early days, we had folks worried that ECM was going to be confused with wraparound, and it shouldn't be. Wraparound, particularly in a high fidelity wraparound environment, is way different. Okay, so ECM is not wraparound. There are specific populations of focus that are the subject of CalAIM, and we should orient to those because this is where there's some pretty concrete connection with our child welfare population where we're addressing the within the comprehensive prevention plan under FFPSA, that piece of the prevention continuum. CalAIM has very tightly adjacent efforts here. So some of the population, I think these are actually all the populations of focus. So individuals experiencing homelessness, again, adults and children, individuals at risk for avoidable hospitalization or emergency room use, individuals with serious mental illness or substance abuse disorder, individuals who are transitioning from incarceration or out of the justice system, adults living in the community and at risk for long-term care institutionalization, adult nursing facility residents who are transitioning back to the community, children enrolled in the California Children's Services program, children and youth in child welfare, there it is, right? So this is one of the populations of focus. And then there's a birth equity population of focus, which has been hard to define in a lot of counties. We're seeing early challenging data around that, but those are the populations of focus. Any quick questions about any of that? I know we have a couple of really smart CalAIM folks in the room, and maybe together we could answer any details that came up. Anybody have questions around the populations of focus and whether or not there's eligibility for a population that you might be working with? All right. Important to understand that CalAIM services are optional. They are not delivered by county mental health systems. They are administered by managed care plans. So Kaiser, Anthem, HealthNet, Partnership, there's a long list, all right? And they have developed networks of community-based providers. Some of you might be some of those community-based providers. If you're not, if you're a CBO lead, I see a few of you in the room. If you're a deliverer of community-based services and you're not yet in the CalAIM network, I know there are challenges with that, but there are ways to get support to get ready and be able to implement enhanced care management and community supports in ways that would help the networks in at least some parts of the state still develop themselves in ways that would increase access. The effort went live in, 4 years ago now, but really hasn't begun ramping up until the last 18 months. And there are, I don't know if I've got a list of all the community supports or not. Yeah, here they are. Then this may be a little old. I want to apologize because I know this has gone through some adaptation, but these are the kinds of things I started to mention a few of them a minute or two back. So think about the risk that your kids and their caregivers have relative to welfare, right? Entry to foster care or the child welfare system. And often it's these kinds of needs that are present, which make them the subject of surveillance, right? Or worry, or the report to Child Protective Services, right? Like we're worried about them because. And if we can, here's the beauty in CalAIM. It's so innovative and so extensive that through the CalAIM network, the community supports network. We can deliver these kinds of supports to people to support them being at home, kids at school, right? Outside of probation, welfare, et cetera. So that's the continuum of prevention-related services. We don't often, within CalAIM, we don't talk about them as being prevention, but they are inherently preventive, right? I hope that's not lost. That's why we're talking about this. Here's a quick list of some recommendations. This comes courtesy to the good folks at the Catalyst Center. I don't know if we have anybody from Catalyst with us, but they've been leaders in supporting implementation and the technical implementation of CalAIM. Important to collaborate and engage community-based organizations in that process. Again, it's technical, so they're going to have help in many cases. If the community-based organization has never billed Medicaid before or Medi-Cal, they're going to need some help, right? You'll want to work with them to clarify and standardize processes so that the guidance to your CalAIM network, if you will, is consistent. Obviously, inherent in this is a promotion and a focus on equity in the funding. So there's an acknowledgement that communities have not always had access to the same services, and the managed care plans are targeted or established and under administrative review with the state in such ways that we're trying to address that through CalAIM. There's a preponderance of need to address decisions rooted in data so that we don't make assumptions about who we're serving and how effectively we're serving. There are focuses on the infrastructure and training necessary because it requires an electronic health record, for instance, and if you're a community-based organization that doesn't have an EHR, you're going to need some help with that. And then it also requires an adaptation of our service models, right? So we have to reassess, just like you've done under the CPP work. Like if you've been involved intimately in your comprehensive prevention plan, you know that you did some needs assessment, some stakeholder engagement, you did some listening sessions, like you identified your gaps that you were going to address with your CPP plan. You've done the same thing with CalAIM, right? And so we can kind of parallel off that effort, if you will. So that's CalAIM. Again, not super deep, but a partial focus there.
Real quick, Richard.
Yeah.
We have a question. Sherry asks, if a child must leave the county to receive medical treatment not available in a rural community, can CalAIM pay for temporary housing out of county?
Temporary housing out of county. That's a really good question. And I will confess to not knowing the answer. I have never had anybody ask that question before. Is anybody else here who's much more aware of CalAIM able to answer that question? Feel free to drop an answer into chat, or if you can find a quick link to resource that by way of an answer, that would be awesome. Good question. All right, that's CalAIM. Let's talk about school-based prevention, because California uniquely has poured billions with a B of resources into school-based wellness centers and to the development of well-being structures and functions and programs and supports in schools, acknowledging that schools are trusted places of engagement, right? So a partial list of some of the school-based prevention include a framework that's been in place in most schools now for at least a decade. They call it multi-tiered systems of support. And it's a prevention, secondary, tertiary, primary, secondary, tertiary framework, similar to public health prevention, that intentionally creates a social emotional learning environment that fosters success for students. This is all premised in the awareness that a young person who graduates from high school, far more likely to go on to trade school, gainful employment, or college, right, in a way that will support them in community as a young adult. In other words, kids that graduate high school are not homeless and they're not incarcerated, at least statistically, right? So that's what that effort's designed to be. And while that's just a framework, inherent within multi-tiered systems of support are state and federal resources to support behavioral health and wellness on school campuses. And the states augmented that with a number of things. Related closely to that multi-tiered systems of support is this idea of school wellness centers. And in almost every county that I know of, there are efforts underway to create thoughtful, accessible, parent involved, integrated in that way. So parent and family involvement, wellness centers. One of the primary tools that's available now to counties and to local schools is the multi-payer fee schedule, or the fee schedule, we call it now. This is the use of federal dollars directly on the part of the school. So back in the day when I had hair, what had to happen was that behavioral health plans had to be the conduit of the federal Medicaid dollar to get the money via contract to schools. And that's not necessarily true anymore. Schools can, through the fee schedule, draw down directly the Medicaid dollar if they can get themselves into a qualified status. And these dollars are finally flowing. So there are various cohorts rolling this out. Again, we're piecemealing this forward. And I think we're into, is it cohort 6 now? Somebody correct me if I'm wrong. It could be cohort 5. But there are dollars now flowing into schools, direct Medicaid dollars, that allow for us to build a deeper and broader continuum of school supports. So that's a quick look at CYBHI. You'll learn more about that in the afternoon session from Mike Lombardo, who's a statewide expert on that stuff. And then the fourth aspect of school-based prevention is this idea of the local control accountability plan. So you may know this as LCAP, right? So these are 20-year-old initiatives, maybe almost 20 probably, which have focused cohorts, populations of focus, including children in the welfare system. So once again, here's that bridge, right, to our primary population of concern. And in every single school and every county office of education, there is an LCAP plan. And that plan is supposed to be focused on how do we help foster youth succeed, or how do we keep kids out of foster care through some school-based support, right? So you see the depth and breadth of the prevention continuum, right? Okay, let me just acknowledge there are 2 or 3 people in the room who are in the process of helping us develop community schools. So if I leave anything out, please know that I would love to have you chime in or correct me if I'm wrong, because I often am. And this is the second area we'll dive deeper on this afternoon. But community schools is a multi-year grant initiative from the Department of Education, which is intentionally designed on integrating the school community environment, if you will. So beyond school wellness centers, and they're not mutually exclusive. So you could have a community school that has a wellness center, but community schools is this idea of integrating in ways that not only allow us to create an environment that's conducive to good learning, but for the school environment to be the place where kids can get sometimes deeper needs met, right? So if there are needs for employment support or housing support or something of that nature, the community school environment is one where at least the information might be available there, right? So if you've seen, let me say as a caveat, if you've seen one community school, you've seen one community school, which is part of the beauty of it, right? Because locally, developers and designers and implementers can create what's going to be useful in that community. So just know that there's going to be some uniqueness to this for sure going forward. The goal here is to have partnerships that provide an integrated focus on academics, health, well-being, and develop the community in ways that make the school much more accessible. There are key features that we'll explore this afternoon in greater detail, including this idea of one-stop shops, if you will, to borrow an antiquated term. There's an idea of family and community engagement, which equalizes power and allows the local school community to authentically tune in, if it's done well, to authentically tune into the needs the parents are communicating. So there's a governance council, if you will, as part of the architecture that informs the professionals about how kids' well-being can be addressed. Closely related to that is a collaborative leadership structure. And in many school communities, this leads to extended learning time and opportunities. So we're acknowledging that, again, schools are trusted places where kids and families will get support. Sarah, thank you for acknowledging student engagement and leadership as additional driving factors in the school community work, community school work. Let me say that I think the dollars have been extended. So the state, in its wisdom, have re-upped the grant cycle. So there's no impending crisis here for the loss of community schools. But what's important for you, if you're in a county system, what's important for you to be aware of is you could have a school partner somewhere developing a really competent, effective community school. And at some point, the Department of Education could decide that these grant dollars, that's all state money, there's no federal money in it. Those dollars are not available to the Department of Education. And someone flips a switch and says 24 months from now or 12 months from now, that grant is going away. All of that community school work that folks have developed over the last 5, 6 years, in some cases, it would go away very quickly if we haven't figured out how to blend and braid the dollars, co-train, cross-train the personnel, right? If we haven't figured out the integration of the prevention continuum, then that part of the continuum would disappear. And we don't want that. That's ineffective, among many other things. Okay, a couple minutes on local control accountability planning. George, remind me, what time do we end our session?
I believe it is at 2:10. Yeah, 2:10.
Okay, got lots of time. The local control accountability plan, again, almost 20 years old, maybe more. I lose track of time, but there are 3-year strategic planning cycles used by schools across the state and the County Office of Education to have targeted, focused funding and planful efforts in 3-year rolling cycles. And they have to be updated annually, and there's data in each one. I will say that sometimes our school folks are fantastic about capturing data that would support our child welfare and youth justice efforts. And we sometimes forget that those partners have data points that will be useful for us to have. So that it's yet another compelling reason to be aware of the LCAP processes, the local control funding formula, and its associated work. The districts and schools that do LCAP, that are doing LCAP work, are required to consult with parents, students, teachers, community members to ensure that the plan reflects local priorities. So once again, if it's done with authenticity, there's this idea of equity, if you will, in the decision-making process, so that parents have a true voice, an authentic voice, genuine voice in shaping the design and the delivery of the services. The state has some priorities. There are 8 of those, and then there's some local flexibility in how the local education authority or the county office can administer that. A critical function of this is targeted support, which describes how additional funds will be used to specifically address unduplicated students who are English learners, foster youth, low income, right? So within your population of focus, you have to address those, at least those 3 cohorts of community members in your plan. All right, that's a quick look at some of those things. Let me pause here for a minute and try to kind of connect the dots for a moment or two. The local control accountability plan, your comprehensive prevention plan under FFPSA, the Family First Prevention Services Act, Part 1, and CalAIM all have specific population focus on foster youth or at risk of foster entry. That should not be lost on it. That's the big takeaway, honestly, from today, is that you're not alone in it as being a CPP designer, a champion. If you're responsible for LCAP, you're not alone. If you're responsible for CalAIM, you're not alone. You've got partners doing the same work for the same kids. And if you can figure out how to get in the sandbox at the same time, you can leverage programs, you can leverage training resources and training needs, right? There's all sorts of things you can do to maximize your effort so that you reduce your administrative burden and sustain your impact. That's the goal. When we see the broad continuum that focuses on foster youth and this idea of preventing entry to welfare, it becomes apparent that the dollars that we have for prevention are not nearly as scarce as we sometimes think they are. So the question then comes forward for us, our county departments and schools that are responsible for this process, are we sharing data? Are we aligning our contracts? Are we sharing outcomes? Are we identifying data and sharing that relative to the gaps and needs for the population of focus? In this case, foster youth or those at risk of entry. So if you're unaware of what the data says from your LCAP plans, if you're in child welfare and you don't know what your county's LCAP plans say about that, there's a learning opportunity, and vice versa for them, right? Same for your managed care plans under CalAIM. They're serving your foster youth or kids, more likely, they're serving kids who are at risk of entry to foster care. And so knowing what they're doing, who they're reaching, how effective they are at gaining, increasing access, those are all um, important pieces of information to know to maximize the prevention effort. All right. Let's talk about 3 or 4 counties. I think we've got some examples here, and if any of you are with these counties, you can certainly help me. This information has been presented over the last couple of years. So in some cases, I wanted to say I may not be aware of changes in the funding architecture or some of the programmatic aspects of this, but let's dive into a few examples. Here's Monterey County and their approach, school-based mental health. And I think importantly, nearly every school in Monterey has now an embedded mental health service on site. In most cases, I think it's 5 days a week, right? And early mental health, of course, is child abuse prevention, right? A kid that's successful in the early years of school, far less likely to find themselves in situations where family stress will impact them in ways that would get them into the child welfare system potentially. The Monterey County system is importantly jointly funded by behavioral health and the local education authority. So schools and the county mental health plan are mixing dollars, and some of the dollars they're mixing together include Medi-Cal, the Behavioral Health Services Act grants, and the School Mental Health Services Act grants. And then there are the about 15 years old now, the AB 114 monies. We know these as ERMS. You might know them as ERMS, Educationally Related Mental Health Services. And those dollars, of course, are ongoing and in some cases grant-based. So there's this really nice continuum of dollars that's blended together, braided together in Monterey County that allows access on every single school site to behavioral health services. Any questions about Monterey? Right. Talk about Placer County for a minute or two, where they've done kind of a long term have had some real success in terms of blending and braiding a host of not just public dollars, but even some private dollars. There is in Placer County a series of wellness centers. So you can see here listed 7, 8, 9 or so high schools and elementary schools, middle schools, where there are wellness centers now in place. And on the right-hand side, you see that highlighted in blue with yellow text that suggests that there's a rich continuum of dollars that's been blended together to support that, including some private dollars from Sierra Health Foundation. So the county was progressive in going kind of outside its own responsibility area, thinking, well, maybe there are private healthcare systems that would want to participate in the wellness of our students. And that's almost always true. So one of the takeaways for you all is to consider if you're in a county where there is a Kaiser Health Foundation or a Sutter Health Foundation or a Sierra Health Foundation, and almost everybody is in a county where that partnership is potential. Think about whether or not they could be engaged to support with some of their philanthropy. And that's what it is. They have philanthropic arms to see if they want to participate in funding services because it's good for the wellness of the community, right? Part of Placer's model is rooted in PBIS, so the Positive Behavior Intervention and Support. So this is true in, I think, almost every district in the state now, but back in the day, Placer was amongst the early implementers. And they have many districts where they not only actively train on it, but they become local experts in PBIS. And the PBIS model is evidence-informed. and has a significant impact in a variety of settings, including school classrooms where it was pioneered, right? And those dollars supporting that PBIS effort include Medi-Cal, LEA, and Kaiser, again, private monies. The effort in Placer includes a community integration in schools effort. So there's a public-private partnership in Placer that involves contracts or mechanisms with nonprofit organizations like Kids First, Lighthouse Counseling and Family Resource Center. They are funded by grants or other resources, and they are part of the community-based integration. So it's not just a public effort, it's public-private. And there's an emphasis within Placer's model on early childhood, pre-K, if you will, through their early childhood ed dollars, AB 2698. So Placer's has woven together, weaved together, I guess is the proper English, a rich continuum of programs and dollars to keep kids, again, at home, in school, outside of youth justice systems, and safe. Right. Ventura is a little more conceptual. It's been a while since I got a deep look at Ventura, but it's noteworthy because what Ventura did is Ventura took the Assembly Bill 2083 system of care work, which some of you are familiar with, and used that as its basis for its wellness system. In fact, they don't call it system of care per se, they call it system of wellness or system of well-being, I forget. But I lifted some quotes from their memorandum of understanding. And I just want to give you a moment or two while I catch my breath to ponder on some of the really powerful words from Ventura's memorandum of agreement for their system of care work, and notice the prevention focus in that. A lot of the same concepts that we heard this morning in terms of equity, access, shared governance. And from Ventura still, their memorandum of understanding includes these things, not all of which are required by the state, but these, so they went a little bit above and beyond. And you'll notice that if you're familiar with the Assembly Bill 2083 work, most of these are required, but notice number 8, which suggests that Ventura, and they're getting closer to this, having a set of outcomes that demonstrate their impact specific to well-being in Ventura. And so they're going to have one of the earlier prototypes of kind of a collective impact dashboard for their prevention work, which will help us identify impact and sustainability efforts going forward in Ventura. Any example, any questions, reflections, curiosities about Monterey, Placer, Ventura?
Question from Nina in the chat asking, can you share a little more about AB 2698?
I wish I could. It's that early childhood money, right? Yeah. As one of my partners, Mike Lombardo, would be the expert to ask about that, but someone could Google that for us, or in a moment or two, if I can get a pause, we can do that and find out. My suspicion is that within AB 2698, there are state Department of Education dollars that support kindergarten readiness, early childhood education, right? So apologize, I don't have a better answer for you because it's not right down my center of experience. But it does remind me, it gives me a chance to reflect a little bit on the reality also that very closely adjacent to the early childhood ed work that county offices of education do. Your first 5, we didn't talk about it today, but in terms of prevention, your first 5 commission is doing tremendous work, most likely in your county. Every county has a first 5 commission with a 5-year strategic plan with populations of focus. By definition in the law, right? This is Prop 10, these are tobacco monies that essentially target the interventions necessary for caregiver wellness for moms and dads who are caring for young children under the age of 6, right? So 0 to 5, or whether there's a young person in a home whose age is 0 to 5. That work is inherently prevented by nature, right? So in almost every county, those strategic plans include the funding of contracted arrangements with community-based organizations doing early interventive work. And so if you're unaware of what your First Five Commission is doing in terms of its 5-year strategic plan, it's yet another place that you could go to for information, supports, and data. Thanks, Liliana. AB 2698 authorizes providers to utilize subsidized childcare funds towards mental health consultation. So it sounds like it's a bit of a waiver of maybe some existing dollars that lets you focus on mental health as it relates to childcare. So childcare dollars would be paying caregivers, like generically. But sounds like if the school district or the county of Office of Ed wants to, they can extend those dollars into services and supports that are designed to focus on the behavioral health parts of that. Let's see. Mary, does Truckee, let's see, my chat just jumped. Does Truckee have examples of these types of integration school wellness centers or other? You know what? Sarah Morgan still with us? Sarah, if you're here, I can't see the whole room, but if you're still with us, this is a question for you.
Perfect. Actually, Truckee is in Placer County, even though the town of Truckee is in Nevada County. So to answer your question, yes, Truckee does have excellent wellness center staff and programs, and they're getting plugged into CYBHI and community partners. However, that's not my department because I'm in Nevada County, but I have collaborated with the Truckee High School in particular, Truckee High School staff. So it's very, very robust program and great staff.
Sarah, thanks. Truckee, if you're unfamiliar, this is another great example, honestly. There's a kind of public-private consortia, the Tahoe Truckee Community Foundation, TTCF. And like most communities, they have a community foundation, but they're very actively involved in identifying needs in the community and supporting ways to meet those needs. And reminds me yet again that when you're doing prevention work, knowing what your community foundation does can be super critical. It'll help you recognize that you're not alone. Let's see. Is AB 2083 mandated in all counties? Yes, it is. All 58 counties are required to have a system of care in place now with an interagency leadership team and a memorandum of understanding, which establishes what the 5 departments that are obligated are going to do. So your child welfare authority, usually housed within social services, sometimes health and human services, the county office of education, the probation department, the regional center that serves your county, and the behavioral health authority, so the county mental health plan. Those are the 5 obligatory. In many of your counties, there are other partners that are already in that MOU, including First Five or your family court, your juvenile justice partners are potentially involved, and so there is an MOU in all counties. Now, I'll be honest and say that there are a number of counties where I think they have struggled to implement their system of care work with kind of consistent intentionality. And so you could go out into your county and say, well, who's doing our 2083 work? And you might get people shrugging their shoulders saying, we don't know, or we don't have that. But I will just answer your question as definitively as I can, which is yes, 2083 is a mandate in all 58 counties, and all 58 counties do have an MOU. I've seen them all. So I do know they exist, but the execution, like all things, is sometimes difficult. Let's see. Thanks, Nina, for doing some research on that. And let's see, we already got to Liliana's comment on that. Brittany, does this include ECMHC, where you help the provider meet the needs of the child? So It sounds like you could be right, but I don't know for sure. Can anybody help with Brittany's last question at 1:44 this afternoon? I suspect that's true. Anybody know? There's an opportunity for some more research. All right. Mary, it sounds like you're familiar with TTCF. Good. Not surprised. Difference between braided and blending funding. Yeah. We sometimes throw around these terms interchangeably and people can get sick of them. The braiding of funding is more technically difficult because it suggests that the county departments are going to share allocations um, to fund a specific employee or a specific function, and it can be difficult to do that. What's far more common is sorry, that's the braiding. The blending would be even more prescriptive, where let me think of a good example here. In Placer County, it's easier for them because they're super agency, but there are individuals in Placer County in the Health and Human Services system of care for children who are funded by both Medi-Cal dollars and child welfare dollars, right? So their time study is a little more complicated, but they're funded by multiple streams. That's an example of braiding, right? You're linking together two specific dollar resources into one functionality for one employee. There are lots of ways to blend resources that don't involve that are a little easier. I'll try to find something on the web here in a second, or in one of my resources that should talk about that. There are some handouts, actually. This is a good chance to reflect. There are 2 or 3 handouts that we did put in the invite to the session. And if you haven't looked at those yet, there could be a better answer to blending and braiding than what I shared with you. And if I've confused you more, I apologize in advance. Let's see, Ashley, are the MOUs publicly available? They are. There's no clearinghouse that's publicly available, but your county's MOU is available. And what I would recommend is that you reach out to your director of child welfare or deputy director of child welfare and ask them to share it with you, right? That is a table where there is great potential for these cross-system discussions. Please be aware that in many counties, they are not necessarily moving that system of care effort upstream. So again, this afternoon in the second session that follows this one, you're going to hear in much more detail about the interdependencies between system of care and a couple of these efforts. So we're going to talk specifically about community schools and CYBHI and how they're dependent mutually on the system, but not every county is necessarily approaching it that way. All right, George, thanks for reminder about the materials, and appreciate that. All right, glad that was helpful, Ashley. Okay. All right, let me jump out of my chat box so I can see my screen again. Okay. So I'm going to try to wind up here a little bit, start to wind down, if you will. We'll probably be done just a little bit early, but that won't disappoint anybody. The important thing to recognize about figuring out the blending and braiding or the sharing of prevention-related dollars is that when it's done well, it allows many departments, to kind of get off what we sometimes call affectionately the grant treadmill. So if you're in a CBO or if you're in some public agencies, your dollars are grant driven, and you have to go through extensive efforts to apply and tremendous amounts of administrative work to petition the state for the grant dollars. And you have to do that every 3, 4, 5 years. And what an effective continuum of prevention services allows for you to do is navigate that in ways that leave you much less susceptible to those grant cycles. You're still going to want to go get that money. But if the money disappears, like I mentioned earlier with the community schools grants, for instance, if that money disappears, you still have resources that can support the service, right? A good example here might be, and I don't think we have very many counties that are super far along on this, but I have pondered it with other folks over the last couple of years, like what would happen if in some counties we were effective at getting the community schools and the comprehensive prevention plan supports in place on the same site. Like if we could endow the community schools as parts of that community pathway, then the child welfare 4E waivered resources that are going to come, they're not quite there yet, but they're going to come with the CPP work, would be leveraging the community school, right? And you'd have this maximizing of the effort in ways that would not only increase accessibility to the prevention service, but sustain the service in the event that the community schools goes away. So I realize this is conceptual. Again, I don't think we're quite there yet in most counties I'm familiar with, but that's the idea. And you can see the power in it, right? It gets you off of that, gets you out of that cycle where you've got to go chase money all the time. Really important, we didn't talk about this in any detail, but each of the prevention efforts that requires a plan be submitted to the state, there's data inside it. Data about needs, data about the kids and the families in your community. And we often sit next to people who have data that would be helpful to us, and we don't even know it. So your peers around the table in a collaborative have done in the last year or two some kind of needs assessment. You did it for CPP. Again, they did it for they do it for LCAP, they do it for First Five. Everybody's doing needs assessment in the community. I was with our good friends in Kings County a week or so back in the course of their system of care work, and their behavioral health lead, their deputy behavioral health director, articulated that they'd had this moment of awareness that in public health, they do the child health assessment. They call it CHA or CHIP or something of that nature, right? And then they identified 2 or 3 other mechanisms that they required in the county to do community-based needs assessment. And they said to themselves, this is kind of silly. Why don't we figure out what the same questions are? Let's ask them of the community one time, right? So they're going to reduce their administrative burden, and they're going to make their data more clear because they're going to be aligned as to how they conduct that needs assessment and use the data in a broader, hopefully more impactful way. Thirdly, if we don't figure out how to share the dollars for prevention, then we're going to struggle for implementation. Most grant cycles take 3 to 5 years to implement, and that's the life of your grant. And so you don't get the chance to really see the impact. Importantly, when we don't do this work well, we have an increase in job position turnover, because if I'm funded by a grant that goes away, I got to go get a different job. So the culture of my organization then is one where I'm on this kind of short life cycle. And so the teamwork and the sense of belonging to an organization that's mission driven can be undermined by the fact that your dollars are simply short term. So yet another reason for figuring out the sustainability and blending of prevention services. And then with great empathy and appreciation for our community-based organizations who feel the impacts probably more than we do in government for being on that philanthropy dependent cycle, right? Because if their public dollars give way, then they're stuck trying to figure out how to raise money. So the bake sales and the raffles and the car washes, right? Those things happen because community-based organizations are deeply mission and vision driven, and the public dollars often fall short. And so they're going out to try to augment and pick up the need, if you will. And if we can be better on the government side at figuring out how to blend and braid our dollars and get them to the right community-based organizations, then they can do less of that, which is going to be a good thing for them going forward. All right, a few years ago, this slide caught my eye. I think it was in this very event back in maybe the second year after we all met in San Diego in person, pre-COVID, but I love the visual that the folks at OCAP put out, and you can see this beautiful house, right? And all the various efforts that go into not just the Family First Prevention Services Act and the drivers of that, but from a larger perspective of creating what would be considered idealistically a little bit still in California, but a 21st century well-being system of care. Right? Like, what if we turn the system of care into a wellness initiative instead of being focused only on foster youth? When it's on some level, it's too late, right? Like, we do good work in child welfare, but that's traumatizing to be in the child welfare system, right? And if we can prevent that trauma for kids and families, then we've done our work even better. All right, some recommendations as we kind of fully wind down here. Your local school districts have resources, and they're often invisible. And here's the thing, you can't go out and ask them for their resources. Hey, share your money with us. Like, don't do that. What you can do, though, is go to your foster youth support liaison, go to your assistant superintendent, your associate superintendent, go to your school principals if you know them, right, and say, hey, we know you have wellness supports on your campuses. We'd love to talk about how we can support them better. Because when you get good wellness services in a classroom, fewer kids are going to come to us at the county. Does that make sense? I hope that makes sense. It's a demonstrable truth. All right. Helping your school partners locally succeed keeps kids at home in school away from your system. Look for ways to align the county prevention work. This is obviously the topic of the conversation, both in terms of the needs assessment and the funding redundancy. So things like your first 5 strategic planning, your Behavioral Health Services Act stakeholder process that is winding down right now. The first one is mostly finished probably in most of your counties, but there's a cycle to that. So you're going to have a next opportunity in a few years to inform the BHSA plan in your county. Obviously, the Comprehensive Prevention Plan reporting and renewal, you all know about that. That's the CPP work. And then within public health, usually the maternal child health reporting and planning, another key area where you can look for alignment. And then have your Child Abuse Prevention Council folks, if they're not already connected to your system of care folks. I know of 2 or 3 counties, and we certainly did this back in the day in Placer, of having a formal presentation from the CAPC to the system of care interagency leadership team. It closes the loop on the prevention efforts, right? So people at that interagency leadership team under system of care have awareness. Once or twice a year, they get a report from CAPC around this is what we've done to prevent child abuse and entry to child welfare. There are other bodies in your county where prevention is a topic. The Mental Health, Alcohol, and Drug Board that your county mental health plan administers, the Juvenile Justice Council that your probation department administers. All of these have community voices that are concerned about the well-being of young people. Obviously, your Board of Supervisors, right? And then in every county, there is a school superintendent's council, and they sometimes meet monthly. It may not be monthly in every county, but those bodies are also interagency on some level and interested in supporting prevention efforts as well in the whole continuum. So I have rambled on far too long. Thought we'd end with just some questions. If they inspire thoughts, either via chat or come off of mute like Sarah did. Thanks again, Sarah. But some questions to think about. Is there a county-wide prevention collaborative? Like, do you have a prevention cabinet that's multi-agency? And if not, think about forming one. If we're not a member, how can I get in? How can I play in the sandbox with my other prevention partners? Which managed care plans or non-government organizations in my county have interest in potential partnership to expand a needed service, particularly from a prevention lens, right? Who are the gatekeepers to that process? How do I find out who they are? If you've done that kind of work, I'd love to hear your expertise or experience there. Which schools or local education authorities are developing community schools? You really ought to know which ones. It's not every school, but there's a lot of them. And who are the people you need to approach there? Is my relationship with the First 5 Commission such that I could leverage data, dollars, human capital? Could we cross-train with community-based providers doing similar work? I'm guessing that in most counties, your comprehensive prevention plan in its next iteration, once we figure out the federal funding, hopefully in the next year, you're going to be doing the same evidence-based programs that are going to be delivered by First 5. on some level. And so that's just an obvious place where we got to look for opportunities to at least share training and admin costs if possible. Are there other bodies or commissions in my county that might help? In Placer County, years ago, we formed a campaign for community wellness. It's public-private. Santa Barbara has something called the Kids Network Policy Council. Every county has something, right? Those are the bodies where you're going to find energy, passion, and power, informed by community. So parents with lived experience, so young people often with lived experience, that's where they are. And if you're looking for access to understand the perspective of your constituents that you're trying to serve, that's a great place to go. So figure out who those are. Anybody with reflections about any of those things, or are there others that I might have missed? Any questions inspire curiosity or thoughts or mass confusion? Complicated, I know. Brittany.
Hi, Richard.
Hey.
I thank you. I really appreciated the inspiration to look at the LCAPs in our area. I was a parent and it used to be on my kids' school's LCAP, and we did make decisions about the wellness of students. And in fact, our school that the kids went to, even though it was a Title I school and had a lot of kids coming to school with community trauma. They wouldn't call themselves a community school, but they did all the things community schools are doing. So I would also just invite folks that if they are quacking like a community school, then they probably are one, even if they don't call themselves that. But I really appreciate the reminder to like just circle back, because um, they're wonderful partners to engage. And then the other thing I was thinking about too was just that in our first 5 commission, we did like a few years ago, we did kind of almost a gallery walk type situation where we were talking about how to serve different cohorts. And we actually did include, even though it was the Pre-Defi Collaborative, about adolescent health. And I am from Alameda County, though, for those who are wondering. And it was actually really important and powerful to look at adolescent health, even as it relates to 0 to 5, because number one, it's not an insignificant cohort of people who become parents at that age, but also because it helps, really help us underscore like what areas should we be helping young people, like now that they're at an age where they can actually articulate some of those experiences, whereas a 0 to 5-year-old, they really couldn't. So really thinking about what resonates for them and what would have resonated for them at a young age. It was very inspiring and very enlightening. So
Love
excited
that.
to share that.
Yeah, thanks for sharing. Those gallery walk kinds of opportunities can be powerful for many reasons. And your reflection earlier about the LCAP and the community schools work, I think that's what Sarah's also suggesting in chat, which is there are many community schools that are not grant dependent. So these have been around for a long time on some level. So I didn't mean to mislead you that the only place you'll find that kind of family resource community center on a school campus is if they're grant funded, because they've existed for a long time in lots of different ways. Every county has something somewhere for kids, and they're often in those communities, zip codes where there is greater risk in the community. So reach out and find them. And finally, thanks, Nina. Love that. And Amador, you had a community assessment, an integrated community assessment. Yeah, beautiful. Yeah, good stuff. And your point here is well taken. And I think that's true, that the policymakers and decision makers more likely to pay attention to it if it comes across their desk and it says multi-agency or integrated, because their first thought is my agency in this somewhere, right? Because that institutional ego kicks in and goes, hey, oh, this is interagency. I better see if my people got involved, right? So you'll get their attention just by doing it in a more collaborative way. Good stuff. Thanks, Nina. All right. Any final thoughts, reflections? We will cut ourselves loose for a little break here and see you back at 2:25. Thanks for joining us. Let me see if I haven't missed anything. Oh, there's some resources. I hope those links are still active. It's been a while since we used this deck, and when you get this, hopefully you'll find some helpful things there in addition to our handouts. Let me stop sharing and express appreciation again to joining us today. And if you want to take a deeper dive on some of the other stuff, some of the stuff we've talked about, join us again in the second session. It'll be a little redundant, I'll just warn you, but hopefully useful. Thanks for joining us.